Okay, so here's something maybe you've wondered about. Can a really common cholesterol medication, like a statin, actually impact something as different as, say, breast cancer survival? It's a question that's definitely popped up in the medical world. Because sometimes, drugs we think we know well might have these surprising extra effects. Or maybe just as importantly, they might not. Today, we're really going to dig into the specific idea. We're exploring the connection or lack thereof between using statins and survival outcomes for patients with early stage HER2 positive breast cancer.
Exactly. And we're basing this deep dive on a pretty solid piece of research. It's a paper from Breast Cancer Research and Treatment, published just this year, 2025. What's key here is that it's an exploratory analysis, but it uses data from a huge, really well-conducted phase 3 trial called Affinity. So the data quality is very high.
Right. And our mission today, as always, is to pull out the most important findings from this study, kind of clear away the jargon, and help you understand what it actually means so you can get up to speed quickly and reliably. So let's start with the idea that we even got this research going. It's quite intriguing. HER2 positive breast cancer, well, it's known for being aggressive, but the good news is that targeted treatments, specifically anti-HER2 therapies like trastuzumab and pertuzumab, and those were key in the Affinity trial, they've really changed the game. Outcomes are much better. Still, treatment resistance can still be a problem.
Precisely. And that's where statins kind of entered the picture as a potential, maybe, helper therapy. The scientific thinking, the preclinical rationale, it goes back to something called the mevalonate pathway. Now, you might think this pathway is just about making cholesterol, but it's actually much more fundamental. It produces signals essential for cells to grow and survive. Statins, as most people know, block this pathway. And the early research, the lab studies, some animal models, they suggested that by blocking it, statins might trigger cancer cells to die off apoptosis, that is. They also seem to potentially reduce tumor growth, maybe slow down the formation of new blood vessels that feed the tumor, and even hinder metastases in some cancer models, including breast cancer ones.
Okay, that sounds promising in theory. But then, as you often find, the real world picture got complicated, didn't it? The observational studies looking at people already taking statins, they were a bit of a mixed bag.
Oh, definitely a mixed bag. You had some studies, even some big meta-analyses combining results that seemed to hint, maybe statins did offer some protection, maybe lower risk of dying from breast cancer or better overall survival, maybe even fewer recurrences. But then just as many other studies came out finding, well, nothing, no positive effect at all. So you have real conflict in the existing data.
Right. So why the disagreement? Was it just bad studies?
Not necessarily bad, but inconsistent. A big part of the problem was how they defined a statin user. Was it anyone who ever took one? Someone taking it currently? For how long? Different studies use different rules, and the methods vary too. All that makes comparing them directly really, really difficult. But there was another interesting layer specific to HER2 positive cancer. Some preclinical work suggested that this mevalonate pathway might actually be an escape route for cancer cells trying to survive those anti-HER2 treatments.
Okay. So if the main treatment is blocking one door, the cancer cell uses this pathway as another way out, and maybe statins could block that escape route.
That was the hypothesis, exactly, which made looking at statins, specifically in this group of patients, the HER2 positive ones, getting these therapies seemed like a really logical thing to investigate.
Makes sense. So let's talk about the Affinity trial itself. Before the statin analysis, what was its main goal?
Right, so Affinity was a major undertaking. Prospective, randomized, double-blind, phase 3, all the hallmarks of a high-quality trial. Its primary question was about adding a second drug, pertuzumab, to the standard treatment of trastuzumab plus chemotherapy, given after surgery that's adjuvant treatment for early HER2 positive breast cancer. Did adding pertuzumab help?
And did it?
Yes, the original trial results showed that it did. Adding pertuzumab improved what's called invasive disease-free survival, meaning less recurrence or death. The benefits seemed particularly clear for patients whose cancer had already spread to lymph nodes.
Okay, got it. So this statin research we're focusing on was kind of piggybacking on that big successful trial.
Exactly. It was an exploratory sub-study. It wasn't the main point of Affinity, but they realized they had all this amazing data collected over years on thousands of patients, including information on what other medications people were taking. So they designed this analysis to specifically look at the statin users within that existing Affinity cohort. It's a really smart way to leverage a valuable resource.
Definitely efficient. And how many patients were involved in this specific look at statins?
They included 4,804 patients from the main trial's intent-to-treat group. And they followed them for a good while. The median follow-up was 6.2 years. So long enough to see meaningful outcome differences if they existed.
And how did they define who counted as a statin user? You mentioned that was tricky in past studies.
Yeah, they were careful here. They defined a statin user as someone who is either taking statins when they entered the trial, so at baseline, or someone who started taking them within the first year after randomization. That 1-year cutoff is important. It helps avoid what's called lead time bias. You don't want to count someone who only started statins, say, 5 years later, maybe because their health was declining for other reasons. That could really muddy the waters.
Right, that makes sense. And what were they actually measuring to see if statins made a difference?
They looked at 3 main endpoints. First, IDFS, or invasive disease-free survival. Broadly, that's the time until the cancer comes back anywhere, locally or distantly, or new cancer appears in the other breast, or the patient dies from any cause.
Okay.
Second was DRFI, distant relapse-free interval. That's more specific, just looking at the time until the cancer returns somewhere far from the original site, like the lungs or liver.
Got it.
And third, the big one, OS, or overall survival. That's simply the time until death from any cause at all.
Okay, so those are the standard important measures. Now, you mentioned before that who the statin users were could be really important. What did the study find about the profile of those patients?
This is really fascinating and absolutely critical for understanding the results. They found 423 patients, about 8.8% of the total, who met their definition of a statin user. And when you compare these statin users to the non-users at the start of the trial, the differences are quite striking.
How so?
So first off, age. Statin users were significantly older. Median age was 62 compared to just 50 for the non-users.
Wow, big difference.
Huge. And linked to that, way more were postmenopausal, over 91% of statin users versus less than half of the non-users.
Okay, what else?
Body mass index, BMI. Statin users had a higher median BMI, 27.3 versus 24.4, so heavier on average.
Right.
But the biggest differences were in comorbidities, other health conditions. This is where you really see why they might have been prescribed statins in the first place.
Like heart disease risk factors.
Yes. Exactly. Diabetes. Almost 25% of statin users had it, compared to less than 4% of non-users. Hypertension, high blood pressure. Nearly 2/3 of statin users versus just 18% of non-users.
Okay, those are massive disparities.
Massive. Coronary heart disease itself was more common, 4% versus 0.6%. And hyperlipidemia, high cholesterol, the main reason for statins, a whopping 83% of statin users had it documented, compared to only about 3% of non-users.
So basically, the statin user group looked, on average, like a group with significantly more baseline health issues, primarily cardiovascular ones.
That's precisely it. There were some other subtle differences, too. Statin users tended to have slightly smaller tumors, maybe, and were a bit more likely to have breast-conserving surgery, less likely to get certain chemo regimens. But the health profile difference is the standout feature.
Which, of course, makes it really hard to just look at the raw numbers and say statins did this because maybe it was the underlying health conditions causing differences in outcomes, right?
Absolutely. That's the classic confounding problem. The groups are just too different at the starting line. If you just compared raw survival, you might mistakenly blame the statin for something actually caused by, say, diabetes or heart disease.
So how did the researchers tackle that? How did they try to isolate the effect of the statin itself?
This is where the statistical analysis gets clever. They use what's called a multivariate analysis. It's a powerful technique. Essentially, it allows you to mathematically adjust for all those baseline differences we just listed: age, menopause, BMI, tumor size, nodal status, hormone receptor status, those crucial comorbidities like diabetes and hypertension, even which treatment arm they were in for the main trial.
So it's like trying to statistically create a level playing field.
That's a great way to put it. You're trying to see what the effect of the statin is after accounting for the influence of all those other factors that differed between the groups.
Okay, the crucial part then. After doing all that careful adjustment, what did they find? What was the bottom line on statins and survival in this HER2 positive group?
The main finding was really quite clear and perhaps a bit anticlimactic given the earlier hype. In the fully adjusted multivariate analysis, statin use was not significantly associated with improved survival outcomes.
Not associated at all.
Pretty much not at all, statistically speaking. For invasive disease-free survival, the hazard ratio, or HR, was 1.11. Now, an HR of 1 means no difference in risk. 1.1 is very close to 1, and importantly, the 95% confidence interval, that's the range where the true value likely lies, stretched from 0.80 to 1.52. Since that range comfortably includes 1.0, It means there's no statistically significant difference. The p-value is 0.54, way above the usual 0.05 cutoff for significance.
Okay, so no benefit seen for IDFS. What about the other outcomes?
Same story. For distant relapse-free interval, the HR was 1.21. Again, confidence interval crossing 1, 0.81, 1.81. P-value 0.35. No significant association.
And overall survival?
Same again. HR 1.16, confidence interval 0.78-1.73, p-value 0.45. So across all three key measures, IDFS, DRFI, and OS, once you adjusted for the baseline differences between the groups, there was no statistical evidence that taking statins improved survival, or worsened it for that matter.
That's really interesting, especially because you sometimes hear about initial analyses showing trends that disappear later. Did that happen here? I think you mentioned something earlier.
Yes, that's a really important point. In the initial unadjusted analysis, just comparing raw numbers between the groups, there actually was a slight trend suggesting statin users had worse overall survival. The HR was 1.62.
Ah.
But even then, it wasn't statistically significant after correcting for looking at multiple outcomes. And crucially, as we just discussed, that trend completely vanished once they did the multivariate adjustment, controlling for all those confounding factors.
So that initial hint of worse survival was almost certainly just reflecting the fact that the statin users were, as a group, older and had more other health problems.
Exactly. It underscores why that adjustment is so critical. It wasn't the statins causing worse outcomes. It was likely the baseline health status of the patients who happened to be taking statins. The adjusted analysis strongly suggests statins themselves were neutral in this context. And they dug deeper, too. They checked if the results differed in various subgroups, like did it matter if you got pertuzumab or not? Were you pre- or postmenopausal? Did BMI make a difference? And the answer was no. They found no significant association in any particular subgroup either.
Did they look specifically at deaths from breast cancer versus other causes, since the statin users had more other illnesses?
They did. They ran a competing risk analysis, which tries to specifically isolate death due to breast cancer. And even doing that, statin use still showed no significant association with either a better or worse breast cancer-specific outcome.
Okay, so the conclusion seems pretty consistent across different ways of looking at the data. But like any study, it must have limitations, right?
Oh, absolutely. And the authors are upfront about them. First, remember, this was an exploratory analysis. The affinity trial wasn't originally designed to test this specific statin hypothesis. That means it might not be as definitive as a trial designed purely for that question.
Makes sense.
Second, there were data gaps. For over half the statin users, 54%, they didn't have the exact start date of the medication. And, really importantly, they couldn't track adherence. Did people actually take their statins consistently? We don't know from this data, so the actual dose or duration of exposure is a bit fuzzy.
That seems like a pretty big unknown.
It is. Also, documenting the exact cause of death in large trials can sometimes be imperfect. And they didn't collect data on lipid levels, like cholesterol, so they couldn't explore if, say, statins only help people who achieved a certain cholesterol lowering or anything like that.
Right, so several caveats to keep in mind, but what about the strengths? It sounds like there were some major ones too.
Definitely. The biggest strength is that this analysis is embedded within a huge prospective randomized phase 3 trial. That framework provides very high-quality baseline data and rigorous follow-up. They had really comprehensive information on the patients, their tumor details, any recurrences, and deaths. That's invaluable. And as far as the authors know, this is actually the largest analysis ever done looking specifically at statin use as a co-medication in patients with early-stage HER2 positive breast cancer receiving modern therapy.
So despite the limitations, it carries significant weight.
Okay, so pulling it all together then, if we distill this down, what's the main message from this deep dive?
The core takeaway from this large, well-conducted analysis is pretty straightforward. They found no evidence of an association between taking statins and having better survival outcomes, whether that's IDFS, DRFI, or overall survival for patients with early HER2 positive breast cancer who are getting standard adjuvant therapy.
So the hopes raised by some earlier preclinical or observational studies weren't really borne out in this more rigorous setting. That appears to be the case, yes. Within the limits of this study design, the data just doesn't support a benefit.
Which leads to the practical recommendation, right? What should patients and doctors take away from this?
The practical advice based on these findings is clear. Statins should absolutely continue to be used for their proven indications, like managing high cholesterol and reducing cardiovascular risk. That hasn't changed. But adding a statin specifically with the goal of improving breast cancer outcomes in early HER2 positive disease, well, based on this evidence, that's not recommended. There's no data here to support doing that.
It's quite a journey, isn't it? From promising lab ideas to conflicting observations, and now a large trial analysis finding no link. It really highlights the research process. And it leaves us with a final thought, something the study authors touched on themselves. They noted that, look, the only way to be absolutely certain about statins and breast cancer would be a massive, prospective, randomized trial designed only for that purpose. Give statins to one group, placebo to another, follow them for years.
Right, the gold standard trial design.
But then they immediately question if such a trial, incredibly expensive, complex, and long, would ever realistically happen, especially given these largely null findings from Affinity.
It's a fair question. Resources are finite.
Exactly. And it makes you think, doesn't it? In this world where we have so much medical information flying around and so many potential ideas to chase, but limited time and money, how do we strike that balance? How do we decide which promising ideas warrant that huge investment needed to rigorously prove or disprove their worth? It's a tough question with no easy answer.